place if you may. We have actually 30 minutes presentations, and lunch has been postponed to 1 o'clock. So the program has been moved to half an hour. So I'm privileged to present Dr. Kamyar Kalantar Zadeh, who's a professor of medicine, pediatrics, and epidemiology at UCLA. He has finished his internal medicine training. He had actually his MD from Germany, from Bonn. Then he moved to the state, where he actually went into internal medicine residency, pediatric residency, and nephrology residency. And after that, he's actually joined many centers, including the UCLA and different schools in the UCLA system. He's also in charge of the dialysis expansion program at Harbor UCLA Medical Center. Dr. Zadeh, actually, he has many awards and grants from NIH, National Kidney Foundations, and American Heart Association. He's associate editor and part of the editorial board in many prestigious journals, including the American Journal of Kidney Disease and Advanced in Chronic Kidney Disease, Journal of Cachexia, and Journal of Renal Nutrition, American Journal of Nephrology. He has published more than 200 journals either as a principal author or co-authors, and at 12 books, chapters, and he has more than over 300 scientific abstracts. His main interest, Dr. Zadeh, is about the nutrition, as you could see from the title of the presentations, and its relation to the kidney disease. And also he's having a great interest in CKD MBD. And we're really quite privileged today to ask Dr. Zadeh to talk to us about management of nutrition and bone disease and renal transplant patients. So we are really privileged to have you, Dr. Zadeh.
Bismillah ar-Rahman ar-Rahim. It's a great pleasure to be here. Thank you, Dr. Saeed, for your kind introduction, and I appreciate the Kingdom and the nephrologists for inviting me. It was a great pleasure to come for the first time to this part of the world and to go to Mecca and to experience this fascinating city. So I would like to start with my presentation. It is somewhat difficult for me to cover the entire nutrition in transplant as well as bone disease in transplant within 25 minutes. It's just an overview, and I hope it could make you more interested, because in my opinion these two topics are somewhat to some extent even ignored by kidney transplant doctors. So I would like to use the opportunity to invite you all in a few months, in 9 months, to come to Honolulu, Hawaii. We have the World Renal Nutrition Congress. Also, for those who come to ASN, I would like to ask you to come 2 days earlier and attend the course for pragmatic clinical trial. With that, I would like to start with the first 2 minutes about obesity paradox. If you look at this now 8-year-old data about obesity and survival in dialysis patients, in the general population, as your BMI goes up, mortality goes up. In dialysis patients, you see the opposite direction. When the BMI goes up, mortality goes down. So this is seen both in Europe and United States, and I can talk over an hour about data consistent with obesity paradox in almost all nations except for Asian Americans in the United States. When the BMI is high, mortality is lower, survival is better. Now this has important implications for transplanted patients and for transplant wait-listed patients. So I'm going to start again to show you data on 54,000 hemodialysis patients from the Vita dialysis facilities, body mass index, and as you can see again, mortality is going down even after exhaustive multivariate adjustments, so that obese and morbidly obese dialysis patients, they live longer. Now, this part, of course, the low or normal BMI, where the highest mortality is seen, could be also called protein energy malnutrition. And this is the field that has been developed in dialysis patients and now is going to CKD3/4 and transplant patients. Now, dialysis patients who lose weight, their mortality goes up, and dialysis patients who gain dry weight, that means they have cramps, and you as a nephrologist, I myself, we need to change dry weight upwards, the survival improves. So, again, protein energy malnutrition and correction of protein energy malnutrition when they gain weight, that means when their appetite improves and they start eating more probably. Now, to make the situation more provocative, when we measured also body fat, dialysis patients who had the lowest body fat had 4 times higher mortality compared to dialysis patients who had more body fat. So, now these were so far data I showed you, and in dialysis patients, again, I can talk over an hour about this. Are there data in CKD3 and 4 patients to get closer to transplant? The answer is yes. Now there are over 8 papers. I'll show you just one of them, showing that in CKD3 and 4 patients also not yet on dialysis, the higher is the body mass index, the lower is mortality. Now, where does it come from? The concept is not difficult to understand. If you look at the biological models, when you deal with hardship, you are equipped with this enormous reserve or capability to reserve nutrition or fat in this case. Now, there was an experiment back in 1950s by Alan Keyes. It's called Minnesota experiment, where volunteer soldiers, they starved themselves to near death. Then they started eating food again, and when they regained weight, it was most fat and less muscle. So indicating that body gives the highest priority to restoring fat. Now, I talk about fat, what about muscle? There are also now emerging data. We measured mid-arm circumference in 792 hemodialysis patients. And after 5 years, what we found that the larger is the mid-arm muscle circumference in dialysis patients, including those who are waiting for a transplant, the lower is mortality. So therefore, we put this here. If fat is good, muscle is better, so that we are not considered fat-centrist. So if you look at muscle, there is actually something else that we measure in dialysis patient, and that's serum creatinine. And assuming a patient receives adequate dialysis treatment, serum creatinine is a surrogate of muscle. So serum creatinine could be considered, and according to ongoing and emerging data in the future, may be used to estimate muscle mass in both dialysis patients as well as in CKD and transplant patients, and in the future maybe in the general population. These are historical data. 20 years ago already was shown that the higher is serum creatinine in a dialysis patient, the lower is mortality. And the same data again, I showed the data from Fresenius. These are data from DaVita showing the same thing. And as to why it is so that obesity or larger muscle mass or essentially larger body size associated with mortality, with better survival, lower mortality, it is believed that overnutrition is of course bad, but the risk of overnutrition, in order to kill anybody, including a dialysis patient or transplant patients, require 10 years or 20 years, whereas undernutrition is a fast killer. In other words, if undernutrition and overnutrition compete, dialysis patients who are waiting for a transplant, they die of undernutrition before they have time to die of overnutrition or before they have time to get a transplant. So this is a simple concept of competitive risk factors and time discrepancies of a fast killer. That means short-term killer wins the competition before the obesity could do anything. So now, moving to recent data, it appears that at least 10%, when I say at least 10%, these are very conservative data, at least 10% of people who are denied of transplant in the United States are denied because of obesity, because of BMI being above 35, and because transplant surgeons have traditionally insisted that they would not do transplant, including my own center. So and it is believed that this is even higher nowadays. Now, one of the papers we published recently in AJT was to look at over 10,000 transplant wait-listed patients and to see if obesity is associated with better or worse survival. And as you expect, what we found among these 14,632 transplant wait-listed patients across all the Vita facilities in the United States, the higher was the BMI, the lower was mortality. So this is, again, nothing surprising, but this, again, has implications for those centers, which are majority, who insist that dialysis patients should lose weight if their BMI is above 35 in order to be qualified for a kidney transplant. Now, what we also found that serum creatinine, which is a muscle mass index, also the higher serum creatinine in months before transplant, the better is survival, the better is even the graft survival. So I forgot to tell you that the data was also about patient and graft survival, which I'll show you more. So now, dialysis patients who are waiting for a transplant and lose weight, their mortality goes up. That means they probably have less chance to be there when you call them for transplant. And if they gain weight, their mortality goes down. So they are more likely to get a kidney transplant. So now, another paper we published in CJSON now about the impact of BMI at the time of transplant, the last 2 months of dialysis, and post-transplant outcomes. So this is more probably relevant to the discussion. And what we found that there was no association. Here there is no protection, there is also no harm. So be it patient survival post-transplant, graft survival, or combined patient and graft survival up to 6 years post-transplantation. Apparently, obesity does not have moderately long impact on patients, on transplant patient survival. Now, we looked at, so these were BMI data. We also looked at serum creatinine in the last few months prior to transplantation. And what we found that patients who have higher serum creatinine just a few weeks before kidney transplantation, they tend to do better in terms of patient survival and graft survival post-transplantation. So probably means that muscle is good and fat is neutral. So here the conclusion was that pre-transplant obesity does not appear to be associated with poor transplant outcomes. Larger pre-transplant muscle mass reflected by higher pre-transplant serum creatinine level is associated with greater post-transplant graft and patient survival. So there was an editorial about this. Actually, all these papers were editorialized, both AJT paper and CJSON paper. And to the credit of Dr. Abbott, who is also a transplant nephrologist, he says that we should probably revise all these, at least some of these criteria about body mass index in this day and age. And in my opinion, this discriminating approach of some transplant physicians to wait-listed dialysis and CKD patients. Now, to be balanced, we also published one more paper in Kidney International this year, and what we found that obesity is actually associated with higher delayed graft function. So now, delayed graft function, since you're all transplant nephrologists, surgeons, I don't need to explain. That means that patient needs dialysis during the first week, and that is also associated with poor outcome. But interestingly, we did not find poor outcome even though the delayed graft function was higher if patient was more obese. So I can summarize this part that high body mass index in transplant wait-listed dialysis patients is associated with greater survival but increased delayed graft function. Losing weight increases death, both pre-dialysis patient and according to our unpublished data also post-transplant. Recommending weight loss to transplant wait-listed dialysis patients has unknown outcomes. I'm trying to say it even conservatively, not to say that it causes harm to patients. So now, how about nutritional status? Something that has not been quite on the radar of transplant physicians is something which we dialysis doctors called, since I do both dialysis and transplantation, we call it serum albumin. Data are consistent that the lower is serum albumin, even 0.2 lower, the higher is mortality in dialysis patients. In my opinion, there is nothing stronger in CKD and dialysis than serum albumin in predicting survival of a patient. And this could also again be called protein energy malnutrition. Over 60% of dialysis patients have serum albumin below 3.8. And it is also seen if serum albumin decreases even by as low as 0.1, mortality goes up. If you do something to increase serum albumin in dialysis patients, mortality goes down. We did this also in PD patients, in 12,000 PD patients, and we found the same thing. The higher is albumin in a PD patients, the lower is mortality. Now, what does it have to do with transplant patients? Another paper that we published also this year in AJT, we looked at the serum albumin within the last 3 months of transplantation and post-transplant patient and graft survival. And what we found that post-transplant patients' graft survival is superior if the serum albumin immediately before transplantation is higher, as you can see. The higher the better, the lower the worse. So both, again, patient survival and graft survival. Now, what to do with this field, which we call renal nutrition in transplant patients? I think now, based on some of our data and by other groups, that the field is developing fast. In dialysis patients, we have shown, and others have shown, that nutritional status associated with mortality, hospitalization, worst quality of life. We have developed malnutrition inflammation score, which is now being used in over 100,000 dialysis patients every year across the United States. And the malnutrition inflammation score is associated with increased mortality in dialysis patients. DaVita has implemented this. Now, in transplant patients, there have been recent data from our research fellow, Dr. Molnar from Hungary. He has also a large cohort in Budapest, and he has shown that malnutrition inflammation score in transplant patients is important. Many transplant patients are malnourished, and that malnutrition, according to malnutrition inflammation score, is associated with increased mortality post-transplant. So I'm going to skip all this data and move to the last 10 minutes of my talk about marrow and bone disorders in transplant. This is, again, another topic I can talk over an hour about. I can show you our recent data about phosphorus and transplant and post-transplant survival. I would like just to concentrate on something which is, we believe is related to vitamin D, but it's not exactly vitamin D. First, PTH and mortality. Recent data shows that the highest is PTH in CKD 3 and 4 patients, similar to transplant patients, the highest mortality. There is an agent that is coming to Saudi. It's called pericalcitol or Zemplar. This is called vitamin D analog, but it's not exactly a vitamin D agent, as I'll show you in this data in the upcoming 5 minutes. So pericalcitol is very effective in lowering PTH in CKD 3 and 4 patients. These are data on oral pericalcitol in CKD 3 and 4 patients. Pericalcitol has been used quite often in hemodialysis patients, and I don't show those data which are quite similar. So looking at what we call vitamin D analogs, the first generation was calcitriol, has been around for over 20 years. The second generations are what we call alpha-calcidiol, totally synthetically. They don't exist in nature. They need to go to the liver to become 1,25-dihydroxycalcitriol. The third generation, which was initially called vitamin D analog, but now it's called selective vitamin D receptor activators or vitamin D mimetic, is pericalcitol in the United States and other countries, and maxicalcitol in Japan. I put here cinacalcet also as a comparative agent, even though cinacalcet does not activate vitamin D receptors. So comparing pericalcitol, which again apparently will come to Saudi in a few months, to calcitriol, if you increase the dose of calcitriol, which is a true vitamin D or active vitamin D, serum calcium increases because vitamin D receptors in the GI tract are activated. Increasing doses of pericalcitol does not lead to that hypercalcemic effect. So that's one of the major differences. Now, switching to transplant patients, we all know that allograft nephropathy, chronic rejection, is our main challenge of 21st century. And I put here also transglomerulopathy because these are patients who have proteinuria very similar to what we see in many CKD 3 and 4 patients. Now, this is one out of many data. I don't need to share with you. This is the calcineurin inhibitor toxicity, which is seen in virtually almost everybody after 5, 8, 10 years. It shows the increasing prevalence of calcineurin inhibitor toxicity in biopsies that you do after a few years. So after 10 years, as you can see, 60 to 80% of all biopsies show some degree of what we used to call in the past chronic transplant nephropathy, or some element of cyclosporine, or I should have called cyclosporine calcineurin inhibitor toxicity. Now, a recent paper was published, which is not quite appreciated by a Korean group. Pericalcital attenuates cyclosporine-induced kidney injury in rats. These are animal models, very fascinating data. And what they found that pericalcital, that is considered, again, vitamin D analog, but is a vitamin D mimetic, reduced the decline in kidney function and profibrotic changes, and also blunted the increased the increased TGF-beta expression and SMAD signaling. Pericalcital reduced expression of pro-apoptotic markers in cyclosporine A-treated cells. So just to show you two of these slides, there are 10 figures in this paper from Korea, and they declare essentially no conflict of interest. Essentially, their research was not even funded, sponsored by the manufacturer of pericalcital. What they found is that adding pericalcital would be associated with less fibrosis in cyclosporine A toxicity models. These are, again, animal models. This is not human data. And across the so-called profibrotic agents and pro-inflammatory agents, pericalcital addition could significantly mitigate the effect of cyclosporine A on, in these animal models. Again, these are not human models. So then there was an editorial in the same issue of Kidney International from our Portuguese colleague, Dr. Rice. The unresolved cyclosporine-induced kidney injury, is pericalcital a feasible new renoprotective agent? And here he says that pericalcital vitamin D analog, which in my opinion should be called the vitamin D mimetic, with renoprotective actions reported in other medications, attenuate cyclosporine-induced kidney injury via the suppression of inflammatory, fibrotic, and apoptotic factors. So this is an editorial to that paper in Kidney International, and this is the figure that they created in the editorial of Kidney International to essentially conceptualize the pathways that pericalcital can improve cyclosporine A toxicity in the animal model. So be it through the anti-fibrotic actions or mitigating apoptosis, or it's actually other arm, which is anti-renin or modulating renin-angiotensin-aldosterone system. And with that, this is actually my last few slides. First of all, I would like to show you or share with you the data of Sotopolsky. Dr. Sotopolsky is the father of bone and mineral disorders, has been publishing this field for 40 years. And what he has shown recently, that giving pericalcital to 5-6 nephrectomized rats actually lowers 1,25 dihydroxyvitamin D. That means pericalcital cannot be a vitamin D if it lowers vitamin D. So any medication that lowers 1,25D cannot be a vitamin D. So therefore, at the same time, pericalcital activates vitamin D receptors. So therefore, it's called selective vitamin D receptor activators, or vitamin D mimetic. Now, looking at something which was discovered completely without any intention, that means when the pericalcital was used in randomized controlled trials to lower PTH, an incidental finding was that patients CKD 3 and 4 who received pericalcital had lower proteinuria. And initially, even the manufacturer of pericalcium was not interested in that. A smart colleague of mine, Dr. Agarwal, published this data in Kidney International 5 years ago, that this is very important. This is a new discovery. And then based on that, a randomized controlled trial, multi-center in several countries was done to see if pericalcitol can improve proteinuria and if this impact is dose responsive. And this paper was published in Lancet. I'm not even part of this excellent group of investigators. And the study had 3 arms: placebo, low-dose pericalcitol, and high-dose pericalcitol. These are now CKD patients. We are not talking about transplant patients. CKD 3 and 4 with proteinuria. They all received ACE inhibitor and ARB, but they are also given pericalcitol. And what was found in this Lancet paper, that compared to placebo, low-dose and mid and high-dose pericalcitol are incrementally associated with improving proteinuria. So this is now my last slide. I talked about first body mass index and nutrition. I summarized those data, and then at the end I would like to summarize the data that I share with you on selective vitamin D receptor activators or pericalcitol. Selective vitamin D receptor activation is different from active vitamin D, and in fact it leads to lowering 1,25 dihydroxyvitamin D level. Selective vitamin D receptor activators can lower PTH effectively, so it is like a vitamin D analog because it also activates vitamin D receptors. Vitamin D receptor activations are associated with greater survival, and these are large number of data that I did not show with, today. All the associative data and survival data in dialysis patients from New England to KI. There are over 12 papers now showing survival benefit. Antiproteinuric effect of pericalcitol is dose dependent. This is the Lancet paper, the VITAL study. And pericalcitol appears to offer protective effects against calcineurin inhibitor toxicity in animal models. And of course, clinical trials are needed to confirm whether this protective effect against nephrotoxicity of cyclosporine and tacrolimus could be shown in human models. So with that, I would like to acknowledge people who work in my research group. I work at Harbor UCLA. I see patients while my students, fellows, and collaborators, they continue doing research and publishing. And I would like once again to invite you to come to Hawaii in 9 months. We look forward to seeing you. Thank you very much.
Thank you very much, Dr. Kalantar Zadeh, for this very new information and interesting data. If there's any question, Abdullah.
I must tell you that I really enjoyed your lecture, and I learned quite a lot from it. And you are right, we don't pay enough attention to bone disease and nutrition in transplant patients. I certainly don't. So this weekend I'm going to go to PubMed and put your name there and try to read all your papers. Yeah. But I want to ask you a question also. Did you almost say that you would not recommend weight loss before transplantation? Did you almost say that? Because, I mean, the standard ruling, we can't convince our surgeons to touch somebody with a BMI over 30. But did you almost say that? And if you said that, at what stage do you go? I mean, even morbid obesity, you don't want them to lose weight, or what?
Well, I appreciate that you very kindly and conservatively and astutely stated what I almost said. And it is always difficult to be straightforward and not to be conservative or vice versa. Our transplant physicians, surgeons, eventually they do surgery. When eventually a patient has suddenly a good kidney match, we usually call them, and they, at the end, they complain that these morbid obese patients, the surgery took 10 hours, 8 hours, but we still put the kidney in. And they still do relatively well. And I share with you the data. Now, what I'll also share with you that dialysis patients who are who are waiting for a transplant, if they are thin or if they lose weight, but again, it was not intentional weight. It was weight across the entire nation. I share with you 10,000 patients. Then their mortality goes up. So and also when I round in my dialysis patients, sometimes I see a dialysis patient is crying in front of my eyes and he says that today the surgeon says, I'm putting you out of the list because you have not lost weight. And half of my patients, half of dialysis patients in the United States have BMI over 28. And it's pretty much universal. So should we continue this tradition or should we have a discussion with our transplant doctor? I have to tell you that the AJT paper, when we published this, there was an editorial by our transplant colleagues, and they were very critical. They said they bashed us from right and left that this data as if it was heresy.
Frank?
Saeed, I won't do as a surgeon, I'll try to limit myself in any bashing of any sort, but these contrary findings that you brought to attention, two questions arise, perhaps. Is not obesity associated with the morbidities that have patients wind up on dialysis? Second question. I mean, just before I leave that, certainly the obese patient has a tendency for type 2 diabetes, et cetera, et cetera. So it would seem to me that your discussion, not going into that realm at all, is a whole aspect of data that we haven't heard. The second piece is when the patient is on dialysis, and we know that the longer the individual on dialysis, the less they become suitable in their candidacy for transplantation. Does not obesity affect that in some way? That the mortality as well, being on dialysis, the percentage of those that die, is that not associated with obesity?
Yes, thank you very much, actually. Now, I completely agree. Data, there are overwhelming, I should put it this way. Obesity is associated with risk of CKD. So there are enough data nowadays. But that's very important. Once you have developed end-stage renal disease, then the role of obesity changes. That's something that we usually do not quite appreciate. Unless you are a nephrologist taking care of dialysis patients, you don't see that. Now, the data of obesity paradox is so huge, it has gone to heart failure patients, essentially are chronic disease patients. That means if you have a chronic disease state, you're better off being obese than thin, then you live longer. And this is a matter of discussion again for 1 or 2 sessions just to look at obesity paradox. So I always, sometimes I've used the analogy of a person, a bad friend, which makes you do bad things and you go to jail, to prison, but he's with you and in the jail he protects you against bad people inside the jail. So obesity is like that. Somebody who caused problem for you, but once you're in trouble, stays and protects you. Now, this is again something beyond and above today's scope of presentation, and we can review the data. Now, dialysis patients who are obese, they live longer. Their data are so convincing in this day and age. And dialysis patients who lose weight, they usually do worse. Dialysis patients whose dry weight goes up, when they cramp, do you have to increase dry weight? They're usually doing better. Dialysis patients whose appetite is better, they do better. Now, while they're waiting for transplant, if you want them to survive until the day of transplant, unless you have immediate plan to give them a transplant within the upcoming weeks, then I think we should consider this emerging data.
Okay, just Saad, just very short, please, because we have to break for. Go ahead. Saad, yes.
When you are faced with a patient with hypercalcemia who's on dialysis and high parathyroid hormone, most likely you will not be able to use baricalcitriol, but you will use siracalcet in that situation, because baricalcitriol would, to some extent, will increase the serum calcium. So can you expand on the effect of baricalcitriol on the phosphorus and calcium in this situation?
Yes, thank you. Actually, pericalcitriol we use Or actually, at least I have 80 dialysis patients every week. I have to round on them. Tonight, when I fly in the morning at LAX, the first thing I do, I go directly to my dialysis center to round on my patients. And almost all of my patients are on pericalcital, so I can tell you just comfortably. And when the phosphorus is high, our calcium is high. When the calcium is high, I try to lower calcium back. All right? If it doesn't work, then in 5 to 10% of my patients, I add cinacalcet. Now, cinacalcet for me, which is called Minpara here, is a secondary agent. It's very useful on those few occasions. And it also may help with phosphorus. With phosphorus, I try to, and we strictly at UCLA or in my center, we do not use calcium-based binders. All of our binders are calcium-free. So we do not see those problems, but we do see, again, in 5 to 10% of the patients, the problem with high phosphorus, high calcium. And we don't, I personally, I tell the fellows, do not please discontinue the medications I've started, and pericalcital. The challenge is to continue that while you control phosphorus and calcium through other things. And also there are data I didn't show today. It was just published another paper of our group this week in CJSON showing that high phosphorus in the last few months prior to transplantation is associated with increased graft and transplant compromise. Post-transplant, patient and graft survival is improved if phosphorus is controlled before transplantation.
Okay. Yes, please.
A very nice presentation. But unfortunately, just the contrary to what we are facing, what we have seen. We have been observing that with high BMR, the results are not good. Maybe something wrong. Now, obesity is associated with the deposition of fat. And now you are splitting between various types of fat, the brown fat and other fat. Do you think the obesity associated with some particular type of fat will react differently than what we think?
Yeah, that's a question that we have currently, to my knowledge, not we, but to the best of my knowledge, there is no data in CKD, dialysis, transplant patient. That means what kind of fat is good, what kind of fat is bad. I sometimes feel not quite comfortable to say that there is a fat that could be good. But data from non-CKD patients has shown, and this is nothing new, I can share with you and you can look up, that subcutaneous fat in the general population has not been shown to be associated with worse outcomes in the general population. That means if you have fat underneath your skin as compared to visceral fat, abdominal fat, you do better. Now we have also another AJT paper I didn't share with you that visceral fat, that means the post-transplant patients whose waist circumference is larger, they did worse with graft survival, and post-transplant patients whose BMI was higher but their abdominal fat was lower, they did not do worse. All right, so that means that there are now epidemiologic data. You can again look up my name, but the cohort is a Hungarian cohort, was published in AJT last year, showing that visceral fat and high BMI, they have two different effects on post-transplant outcomes. So that goes to your probably discussion, because visceral fat is different fat than subcutaneous fat.
This is about the site of deposition of the fat. But I was talking about the nature of the fat. You have got brown fat and white fat and some. So is there any difference between the two?
No, there is no data essentially. Nobody has done any biopsy. As I said, indirectly based on site of fat, we can just make maybe some inferences. But to my knowledge, no, they have not been done, and this is one of the areas we need to do more studies.
I thank Dr. Rizvi and thank Dr. Kalantar Zadeh. I'm sure this presentation has really generated lots of questions and interest. I'm sure everybody is interested. But we have to break for the lunch and prayer, so we can reconvene back at 2 o'clock. Thank you, Dr. Zadeh. Thank you very much.
Thank you.
Reconvening at 2 p.m. Thank you.